Erica, thank you so much for joining us. We have started another round of ECMO specialist workshops, and today we'll be talking about ECMO mobilization. So thank you for joining us. Thank you for tuning in, everybody. Erica, can you just share a little bit about yourself, who you are, and what you do?
Yes. Well, I want to first off say thank you so much, Nicole, for having me here. I'm super, super excited to be talking about a topic that's very near and dear to my heart, caring for and helping mobilize patients who are supported on ECMO. A little bit about me. I've been a PT for 17 years. It'll be 17 years at the end of this month. Time flies. All of that has been in the acute care setting, and the last maybe 12 to 13 years solely in the critical care setting, and specifically in the CV ICU. I started taking care of patients supported on ECMO in like 2016, 2017, when kind of in the infancy of our facility's ECMO program, and was kind of raised up by a bunch of really amazing bedside CVICU nurses, CVICU clinical educators, doctors, physicians, but got really interested in the care of patients supported on ECMO, and that kind of drove me into doing a cardiovascular pulmonary residency, and then sat for my cardiovascular pulmonary specialist certification in 2016, 2017, and have here in the last couple of years gotten really interested and really involved in the education side of patient care. And so that's why I'm here talking to you. So thank you again for having me.
Awesome, thank you. And I know you're so passionate about ECMO mobility. So can you just share with us a little bit about why you're passionate about it and what you love?
It comes down to the patients being able to make some sort of difference in this patient's journey, from a episode of kind of being put on ECMO, very probably unexpected event in their lives, but being a part of the team that kind of helps move them through that and gets them to the other side. So the human connection is what kind of keeps me coming back. There's also, I love the critical thinking, clinical reasoning part of it, and kind of the interaction with the interdisciplinary team. So being involved with each and every member of the interdisciplinary team, and kind of again collaborating to taking care of these patients. That's what kind of keeps me coming back for more.
Awesome. And then you had mentioned earlier that you received a special certification in cardiothoracic or cardiopulmonary. I can't remember which one you said, physical therapy. And I had
Yes.
never heard of that before you had shared it with me. So can you just kind of dive into that a little bit? Tell us about the training, what's required, and when you come
Sure.
out, what is different between a standard certification and the certification that you have?
Oh, that's a fantastic question. So it's a cardiovascular and pulmonary specialization. Clinicians can go or kind of two roads to get to specialization. You can do what I did and apply to a residency program, so a clinical residency program, and it's a program that's run by physical therapy department or an entry-level DPT program with some post-doctoral specialization. So the DPT program runs the residency program, and it's affiliated with usually a obviously major hospital system, and it's a year long. And the crux of it is there's a didactic component where you're kind of reinforcing cardiovascular pulmonary principles, anatomy, physiology, pathophysiology, but the best part of it for me was the clinical mentorship. So being paired with a senior therapist who has been in practice for longer than you, seen more than you, and you actually get to sit down and talk about those patients that are giving you what am I doing? What am I seeing? Why am I seeing it? How can I intervene here differently? So they're really kind of sharpening your clinical reasoning skills, your evaluation and your assessment skills. So there's the mentorship piece, there's the didactic piece, and then there's the program actually encourages clinicians to kind of shadow and see how other disciplines within the healthcare team works. So being able to shadow cardiologists, interventionalists, surgeons, respiratory therapists, nurses, and seeing kind of their lens and view on patient care and patient management, so that then as a clinician, I can take that back and kind of, again, incorporate that into my clinical reasoning and my patient management. So again, it's a year-long program. And at the end of it, you sit for a specialization. So it's a test that takes about 4 to 6 hours. But you take the specialization, and then you find out maybe like 3 or 4 months later that how you did, and then it's a specialization that's good for about 10 years, and then you have to like recertify. And we didn't used to have to do that. And initially I was like, what? We have to recertify? You do all this and you have to recertify? But in thinking about it, it's really nice that you have to recertify, and you have to show over that 10 years that what kind of patients you're taking care of, what clinical, where are your clinical strengths and areas of challenge, how are you resolving those things, how are you incorporating evidence-based practice into your clinical practice on day-to-day. How are you being a good steward of the profession and giving back to students and other potential residents? So we do that along that 10-year process, and then you sit again just to make sure that you're up to date on the latest and greatest and all of the things. So that's the one. You can go down the residency path, but you also can be a clinician who's out of removed from your postdoc PT program and have a certain number of hours of clinical practice in the cardiovascular pulmonary setting. So it can be inpatient, outpatient, and then once you document those hours, go through the steps to document those hours, you can then sit for the specialization. So no mentorship, no really kind of reinforcing of those and cardiovascular pulmonary anatomy, physiology, kind of foundational concepts, but you can also take that road. You don't have to do a residency. Did that answer your question? I know it was kind of long-winded.
It did. No, that's
okay.
Perfect. Thank you.
Mm-hmm. So we are going to jump right into discussion of principles of ECMO mobilization. And then I'm going to share here my objectives. Not a whole lot of objectives, but I feel like this is going to be a pretty dense lecture, but not a whole lot of objectives, but I'm hopeful that we achieve these. We're going to talk about the benefits of early mobilization, some specific to ECMO patients and some specific just to kind of the critical care patient population as a whole. We're going to talk about how ELSO recommends that a program considers incorporating mobility as part of their patient management. Hopefully it's not on a Monday we decide we want to do mobilize ECMO patients, and on a Friday we're doing it. There's the process of kind of fleshing that out, what it looks like, both from a planning standpoint and a clinical standpoint. We're going to spend the majority of the lecture or the talk talking about clinical considerations for mobilization of patients supported on ECMO. So the how, what does it look like? What does it look like, feel like? And then we will talk in depth about over and over and over again about the key members of the mobilization team necessary to pull this off. Who needs to be there? What are their roles? But more importantly, what communication needs to be had between these members of the mobilization team to make sure that this process is undertaken in the safest manner possible. So we're going to scroll down. So we're going to first, as I said, start with evidence. So I like to start with what we know. What we know is that patients who are critically ill are more susceptible to the deleterious or all the badness of being ill is going to be ICU acquired weakness and delirium. And what you can see in kind of the data, what the data is going to show us is that these patients have at an increased rate of or increased risk of staying in the hospital longer, staying with us longer, increased ventilator days, and sometimes an increased rate of mortality. So what we know is that we let patients lay, they get weaker, they stay with us longer, and they're more susceptible to other kind of bad things happening as a result of hanging out with us. What we also know is that patients who have acute respiratory failure as a diagnosis and are kind of wandering down or meandering down that road to tracheostomy, in combination with lacking the ability to mobilize early and often, have a higher readmission rate and a higher incidence of mortality during that first year post-discharge from the hospital. So thinking about that, when we're thinking about who do we mobilize and why, using this information to kind of help, if for lack of a better word, kind of risk stratify. If we have those patients who are not moving, who are wandering down that road of tracheostomy, maybe those are the patients that we should be kind of targeting more when we're looking at or starting to think about early mobilization. What we know about mechanical ventilation is that once we put that tube in the patient's throat, once we put them on that ventilator, that's kind of starts the clock to like this rapid muscle wasting that's seen in the critically ill patient population, especially those patients who are diagnosed with a multi-system organ failure, have that multi-system organ failure diagnosis. So we put the tube in and kind of it starts the clock on muscle wasting, not just from a kind of peripheral standpoint when we think of arms, legs, but also from that pulmonary, pure pulmonary standpoint from the muscles of respiration. What we know about patients who are supported on ECMO is that patients who are immobile during the management of ECMO have a risk or higher risk of physical impairments that lead to a prolonged hospitalization and then poor functional outcomes. And so that concept of we're not just looking for getting these patients on the circuit, supporting them through, we're really looking at creating not just survivors, but patients who are thriving post-ECMO support. And what we know is that patients receiving ECMO as a result of kind of probably a combination of things, the immobility, the critical illness, the lack of mobilization, their nutritional status, but these patients are at a greater risk for developing issues regarding skin breakdown. So that's a review of the data, so the what we know part. So what has been done to kind of help pull clinicians together and kind of provide a really thoughtful, very, for lack of a better word, A through F, like a very stepwise progression to management of patients to kind of help combat those deleterious effects of immobilization is the creation of this A through F bundle, dealing with things from like, how do we assess pain? How do we manage pain? Are we giving the appropriate drugs? Are we waking people up so that we're not awake, sleep, awake, sleep, awake, sleep, and contributing to that, that potential development of delirium? But the piece I want to hone in on is this, and we'll talk about here later in this talk, is that early mobilization and early exercise. And again, the data supporting that when we get patients up, we mobilize them soon, often and early, we can kind of help prevent these deleterious effects of immobilization. What I'll also add about the A through F bundle is that it's done, or the best outcomes for our patients is when we do it in its totality. So we're not just assessing pain and mobilizing. We're assessing pain, we're managing pain effectively. We're those patients who are mechanically ventilated, we're waking them up, we're extubating them. It's really the total bundle of things. It's not the kind of pick and choose option here. What we know about early mobilization in general is that physical rehab and mobilization has improved both physical function of our patients and reduced the length of stay compared to standard care. So compared to like just standard care, doing what we normally do, when we get patients up, we mobilize them, we have the ability to impact length of stay and their outcomes post hospitalization. When we're comparing to usual care, it's safe to mobilize patients, and with the caveat of when there's appropriate education and orientation, it's safe to mobilize these patients when you look at, do bad things happen when patients get up and move around? And then it needs to be a whole body kind of approach to mobilization. We need to think of the patient as a whole when we're looking at what we're doing to kind of get better outcomes. And as I said, relative to the A through F bundle, the not picking and choosing, it's really all of it in its totality that's going to make the biggest impact on our patients. Again, just some additional data about relative to early mobilization and kind of completing it in its totality. But what I'll highlight here is that third bullet point down, that active physical rehab and including ambulation can be done safely when there's an experienced multidisciplinary team, right? There needs to be experience and there needs to be, again, consistent education to make sure we're doing the most appropriate and safe things for the management of these patients. What we know relative to physical and occupational therapy practice in the acute and critical care setting is that to be safely practicing in this setting as a PT and OT, there needs to be a superior knowledge of cardiovascular and pulmonary function, pathophysiology, normal physiology, how the medical management and or surgical or interventional management of these patients is going to be impacted by or can influence therapy, and then all of the things, all of the technology we see in the room. What does it mean? What information is it giving me about the patient? How, again, is it going to impact therapy? And how can it, and the fun when you get to like talking about ECMO patients, the really fun part is when you can start using the circuit to support the patient to get better functional outcomes. That's when you're working at a really high level regarding mobilization of patients supported on ECMO. This is a little bit of older data, but I think it highlights kind of the work still to be done relative to the management of the ECMO patients supported on ECMO. So this is from 2020. It's put out by ELSO. It's their annual organizational report. But when you look at the ongoing needs of patients after separation of ECMO, discharge from the hospital, kind of the highest kind of percentile of kind of ongoing needs, it's going to be mobility issues, depression and or other mental disorders, and then memory loss. And when you go back and you look at the A through F bundle, the A through F bundle is designed to manage all of those things, right? Mobilize patients early, keep them awake, keep them alert, keep them engaged, engage the family, and the creation of the ICU diary so that they can start putting the pieces together. What happened to me during this stay? Because our brains like a story. We'd like it to be the correct story. So if you have the ability to get them that ICU diary so that the family can start chronicling what's happening as they're there, it helps, again, their outcomes on the other side of ECMO support. So we're going to talk about now transitioning into establishing a safe mobilization or rehab program. What does that look like? We're going to talk about principles of mobilization that come from the ECMO specialist guidelines or the specialist manual. I don't know why that didn't carry over. That slide didn't carry over. But I kind of know them off the top of my head, so I can recall. So also recommends that it's a programmatic approach to consideration of mobilizing patients supported on ECMO. So what that means is all stakeholders at the table hearing the same thing at the same time. right? In the program I was working in, as the program grew and we were getting more pumps and getting more patients on, it was great that we were being able to help patients. But what we found is, like, when the program expanded and we got more pumps, no one thought, hey, that means we need more FTEs from a PT and OT standpoint to support these patients who are on ECMO. So being very, very conscious of all stakeholders at the table hearing the same thing at the same time, so that they then can make decisions and about resources that are needed to kind of mobilize patients safely. One of the other considerations is, what kind of patients are we going to mobilize? So if you have a VA and a VV program, are we just mobilizing VA? Are we mobilizing VA and VV? Are we doing peripheral cannulation, central cannulation, only the dual lumen cannulations, only the patients who are bridging to transplant, only patients who are bridging to a device? Like, being very thoughtful about, again, which patient population you're choosing, and then how you're going to roll that out to the staff, and starting potentially with the patients who are quote unquote more stable, and then working towards those who are a little bit more critically ill and require a little bit more resources and time and training. So starting with those patients who are, again, a little bit more stable. That there is consideration for airway. So when we were thinking about patients who have artificial airways, who needs to be present if your patient has an artificial airway? Is it every single time a patient gets up with an artificial airway, respiratory therapy is in a room? Or is it only if the patient has a difficult airway, respiratory therapies in the room, or there's a provider in the room, or cardiac anesthesia, or whomever manages your difficult airways has to be aware? But being very conscious and very thoughtful about who needs to be there, again, with respect to management of airway. There's also the need to really define out what is mobilization for your program. And people think that's like, oh, well, mobilization means patients get up and move around. But really, what does that mean, right? So are we talking, we're mobile, like everybody will get up and everybody walks, everybody will be, which is maybe not realistic. Is it patients will be able to tilt? All ECMO patients will be put on these vertical tilt beds and allowed to be progressively tilted up to a 90-degree and then walk off the edge of the bed? Is it, no, the only patients who are going to get up and mobilize again are those patients that we're bridging to transplant initially? And then what does that look like? Is it like they're up and they're walking 3 times a day or 6 times a day or whatever, what have you? I was on a call with a facility up north in the Northeast, and they told me that their patients get 2 hours of PT and OT a day, which I think is amazing. But I'm like, how did you pull that off from a resource standpoint? Like, how did you pull that off from a resource standpoint? So I think the take home here for this slide is being very thoughtful about how you roll out mobilization, so that all stakeholders are at the table and everybody's hearing the same thing at the same time, so that appropriate resources can be allocated to the process so that it can be done safely, is the take home here. With respect to the multidisciplinary team, by all means, this is probably not all inclusive. I would say any and everybody who walks in a room with a patient supported on ECMO is a member of that multidisciplinary team. But the medical team or surgical or interventional team that's managing the patient, the bedside RN, the ECMO specialist and perfusion, just whomever manages the pump at your facility, respiratory therapy, rehab, nutrition. One of the surgical directors of our program used to say, with respect to ECMO patients, you weed, feed, turn. So if we can make sure patients are free of infection, we can feed them adequately, and we can mobilize them, we're doing a really good job. But again, it takes a multidisciplinary team to do that safely. With respect to education and competency, deciding as a facility, how are you going to manage education? Is it only didactic? Is it didactic and hands-on skills? Or is it a hybrid, a mishmash of those two things, where clinicians are able to actually put their hands on it, feel it, touch it. I like to say, like, mess it up, do the things, do all the things, make the alarms happen, make the decisions in a very controlled environment so that it's safe, so that when you get out to actually managing a patient, it's more of a muscle memory kind of thing, and you're not really having to think I don't want to say intentionally, but you've seen it, and so you recognize it, and it becomes less a burden to kind of have to think of some of these smaller details. Is it going to be all disciplines get this general foundational knowledge, or is it going to be discipline specific? So rehab needs, cardiovascular pulmonary foundations, they need lines, tubes, wires, they need ECMO basics, but what does that look like for a rehab professional? Being very kind of intentional about the education that's provided to each discipline. And then the fun part, how are you going to track it? And then and track and maintain it, which used to be my job: track, maintain, update it. And then policy and procedure. And so when you start out and you're starting to mobilize these patients who are supported on ECMO, what does your policy and procedure look like? And being safe, obviously, but not being so detailed that you're boxing yourself in and you're always having to update policy and procedure. Because I like to say, you give docs cannulas and they'll put them in the oddest places sometimes. And then you're like, yeah, this patient is like, you're having the clinical one-off conversation about this patient's cannulation strategy. But when you go back and look at the policy and procedure, you're outside policy and procedure, which may be a good thing then to have that conversation. So we have this policy and procedure in place. We don't do this because of this. But as a general rule, being aware of what policy and procedure is going to be in place to drive the management of patients, of mobilization of patients supported on ECMO. With respect to PT and OT, our role amongst that multidisciplinary team are going to be addressing each strength, balance, coordination, cognition deficits. But basically, we want this person to get back to being who they were from a functional standpoint, from being able to get in and out of their bed, stand up, sit down, walk, take care of themselves, go to work, be an active member of their community. Our jobs are to get that patient back to that, as close to that as we possibly can, if at all possible. Earlier in the presentation, I spoke about kind of the necessity that all rehab folks have an awareness of kind of cardiovascular pulmonary, pathophys, lines, tubes, wires. But Chris Permy actually just came out with a rehab ICU competency, which is really great. It's kind of in its infancy, in the first stages, kind of vetting it. But what the concepts or the major topics that stuck out relative to being a rehab service professional in the ICU and being safe, and I don't like the word competent, but being safe is going to be, you have some concepts or some understanding of how the ICU in general works, that you understand what assessment tools you can use as outcome measures and or evaluation tools, be it auscultation, be it manual muscle testing, be it how do you interpret vital signs. You have an understanding of pathophysiology, and I would say understanding normal physiology, so that then when you put a disease process on top of it, you understand how that disease process then impacts the system. Because in the ICU, there are kind of, I think sometimes we're stuck in these, patients need to be in these normative values, and we chase numbers. I will speak as a rehab clinician. We're kind of like, the order set says the patient's heart rate has to be normal sinus between 60 and 100 beats per minute. If those were the parameters I worked within every single day, I would see no one, waiting for that perfect kind of golden goose of like heart rate between 60 and 100, normal sinus rhythm. I wouldn't see anyone. But I think the biggest take home here is understanding what's normal, what's pathologically normal, and then how pathologically normal would then impact the patient's participation with therapy. Looking at the patient's imaging and lab values, and being able to make decisions about how that is going to impact their potential to mobilize? Is it going to impact their how's their oxygen consumption going to look? How's their hemodynamic response to activity going to look? How cognitively are they going to be able to attend to my directions? You can get all that looking at imaging and labs. And with respect to labs, understanding that it's not like the finite number sometimes. Sometimes that finite number can tell you, oh, this is all badness, I'm walking away. But really, it's that trend in numbers. Where's the trend going? And then being able to take that information to the bedside and having a good conversation with the team managing the patient, saying, so, hey, I saw H&H was low today. What are we going to do? What's being done to manage that? Are they going to get some blood? They're not going to get some blood. How many units are they going to get? Can I get in between the first and second unit? Being, again, able to take that information and having good clinical conversations about the patient. Understanding drips and drugs and sedation. So hemodynamic drips to the point of understanding why the patient's on it. Because I like to tell the nurses is a good tell for me. So if somebody's on, some levo and we wean levo right before we walk in the room, the decision's made to kind of wean a little bit of that support. I have a tell about how this patient may potentially decompensate or show intolerance to activity. Their blood pressure may not handle it because they've come off of a little bit of the levo. And again, understanding how these drips and drugs support hemodynamics so that then you can make, as a clinician, decisions about how we progress the patient. Same with sedation, understanding kind of what they're using and why, and starting to have that conversation sometimes that's like, I'm asking to like turn it down, not off. And, understanding where they are in dosages of their sedation medication relative to RAS goals. So again, you can start having these conversations so that we can kind of be pro-mobilization. With respect to supplemental oxygen and mechanical ventilation, I say you have to understand how oxygen is being delivered so that then we can make a plan about how oxygen will be consumed with therapy. So just being aware of what device they're on. And with respect to mechanical ventilation, the modes of ventilation is great. With respect to critical care lines and tubes and devices, understanding what information the line, tube, or wire is giving you is great. I say that kind of the 4 things to understand about critical care lines, tubes, and devices is what information is it giving you? Where is it at? Is it in a artery, vein, body cavity, airway? Because it's all, whether we know it or not, it's giving us information about our patient. Should I trust the information it's giving me? Because sometimes the information is cannot be as accurate, right? We can make the information more or less accurate. And then with respect to these lines, tubes, and devices, if they come out, oh my goodness, what do I do? What is the response? What's the most appropriate thing? What am I going to do to kind of help fix that? How big of an emergency is it? And then the interpretation of vital signs. So understanding what tolerance looks like and intolerance looks like. I think it goes back to understanding pathophysiology and understanding oxygen delivery and oxygen consumption, so that you can recognize in specific patients when you need to when you can push and when you can't push. I wish it were like some things are not very, black and white. Like we do not, this blood pressure looks a little marginal and their heart rate response is a little marginal, but maybe I can get another sit to stand out of them. Or maybe it's not box squat and burpee day and we will just do some seated exercises at the edge of the bed, but really having a good understanding of how the patient should respond, giving their underlying pathophysiology, and then goal setting and documentation. You need to be very proficient in your goal setting and documentation. And I would say having a working understanding of how the underlying pathology is impacting the patient as a whole and what the team is doing helps you as a clinician set more realistic goals relative to patient management. I say to the docs all the time, if you can't fix it from a medical standpoint, then I can't fix it. I can't fix it's whatever it is. I can't fix its impact on the patient's function. So instead of trying to fix this, I need to teach the patient an adaptation for how this is impacting their function, because the thing is not going to get fixed. Chris and her group were also really great about outlining kind of mechanical circulatory support devices specifically. And I won't go through all of this in detail, but having a general understanding of, again, what the device is doing, how's it supporting the patient, are there precautions, how does this device work, and should I be in the room with this patient who is supported by this device? And it's not as clear cut as we, I think, once thought relative to these devices that, patient has. So again, as patient support on ECMO, they need to be laying in bed, as an ECMO specialist who I love once said to me, he was like, they need to be, in bed, head turned to the left, RAS of -5, intubated, sedated, don't touch them. Walk away, Erica. But that's not necessarily the case. If we can, as again, PT, OT, we can understand these kind of criteria, then we can manage these patients safely relative to mobilization. So some specific mobilization consideration. So I love this graphic. I wish I could take the credit for it, but I cannot. I saw it at a ELSO conference a couple years ago, but I think it speaks volumes for the necessity to why, as clinicians and specifically as rehab clinicians, we need to understand it all. We walk into the room and we see the little circle in the middle. We see the patient, which is basically the makeup of oxygen delivery and oxygen consumption. And sometimes you can lose, what can be lost is that when you are putting the demand on the patient, whether we know it or not, we are impacting how that mechanical ventilation is able to support the patient, or we are impacting how ECMO is effectively able to support the patient. So as you're going in the room and you're asking things of this patient, you're affecting this whole big puzzle. And so as a clinician, this is why we have to understand all of this, so that we understand what we're doing. Is what we're doing the most appropriate thing? How do we dose it? How do we, recognize intolerance? How do we recognize, they're getting better, we can add more, or they're not getting better and they're not responding, we should not add any more, we should stop. So relative to cardiac stability, the things we're going to look at are kind of same on as most cardiac patients in the critical care setting. So all these indices and markers of cardiac stability, we're going to look at that, but we're going to look at it through the lens of ECMO, with the consideration that ECMO doesn't fix anything, right? ECMO doesn't make it better. ECMO takes the work off the organ system so that the organ system can get better if possible, right? And so looking at these sometimes vital signs through that lens is very helpful in trying to figure out, should I be in the room or should I not be in the room, right? If the underlying organ system is showing like complete intolerance or instability, no, maybe mobilization is not that person's jam today. Maybe that's not what we should be doing. But as the organ system starts to show the ability to recover, we can start adding more stressors to the patient and start, again, monitoring these things as we add stressors to kind of assess for a tolerance to activity. Same with relative to pulmonary stability. Again, ECMO is not going to fix the lungs. ECMO lets the lungs rest. And so understanding what we're looking at from a pulmonary standpoint as markers for pulmonary recovery, and then how, as therapists, are we going to, or as the team, how are we going to stress the patient appropriately, but still allow this organ system to recover? And so, again, a working knowledge of all of these things relative to kind of through the lens of ECMO, so that we understand that what we're doing is the right thing for the patient at the right time. Relative to the patient specifically, we're going to look at RAS and cognition. As this illustration, kind of the picture down here at the bottom, you see the patient in the middle. There's a lot of stuff attached to these patients and supporting these patients. And so if we don't have a patient who's awake and alert, and able to communicate to some degree, right? Not everybody can be wide awake, off of no sort of sedation. Not everybody can be that way, but people can be awake enough to participate and safely communicate. I say to the nurses, I need the patient to be able to communicate intolerance to me. I see what these numbers say, but I also want to be able to know that the patient the patient can communicate to me, hey, this hurts, or I am lightheaded or dizzy. Even if it's like, stick your tongue out. We sit up on the edge of the bed and you get lightheaded or dizzy, stick your tongue out. So I know that you're lightheaded or dizzy. Do you understand that? Yes. Give me a yes. Okay. So establish some means of communication that we're effectively controlling the pain, the patient's pain. We've talked about medical stability, but on the previous slides, but really being certain that the patient's medical stability is trending in the right direction. And then that we're really assessing the patient's cannulation site. So the cannulation site is, sometimes these cannulation sites can get oozy and nasty, but making sure overall that the site is stable, that sutures are in place. I like to say about critical care lines that suture is a suggestion. Like, is this a suture to nowhere? Is it like actually wrapped around the cannula in the skin? Because these patients' volume status shifts and changes so much. Their volume up, volume down, volume up, volume out, down. And those sutures are just being stressed as we kind of manipulate, or as the patient's volume changes. And so is that suture in? Is it tight? What's the cannulation site look like again? Is it bloody, oozy? Is there presence of hematoma? And then our anchors and in place, right? And so in this particular illustration, we have kind of the pads and the anchors in place that are kind of securing the cannulas, which are great when the patients are laying down. But when you're thinking about, okay, you're going to try to sit this patient up on the edge of the bed, those anchors that are securement devices that are in place at like joints that bend, they're just going to cause more torque and tension on those on the cannula, on the tubing. And so making sure that we've secured at places that are going to provide stability but are not going to be mobile and potentially limit mobilization and or cause extra stress and torque. And again, for our program, what I like to do is I like to plan the mobilization from supine to sit to stand, whatever we're going to do. I like to make sure that there's enough slack, there's enough, the anchors are placed in places where there's enough kind of, again, it's secure, but that there's not going to be places where, oh, when we stand, there's a lot of slack or there's not enough slack. So we really go through and make sure that they're, okay, when they sit up, this is how much slack. And so we're going to put the anchor or securement device here so that we're not constantly changing anchors and securing devices throughout the treatment session. We talked a little bit about the evaluation of the cannulation site on the other side, but what I will also add here is that with those patients who are femorally cannulated, if you're a program that's considering mobilizing patients who are femorally cannulated, that you're doing a really good vascular exam, that you're really assessing the potential for vascular compromise with mobilization. So what we do at our facility is that patients laying in bed, we come in and we sit the head of the bed up. Well, we do a baseline vascular exam. So we're looking at sensation, we're looking at cap refill, motor, the temp, we're doing a really good vascular assessment of the cannulated lower extremity. And then we sit the head of the bed up and we get up to maybe 60 or 70 degrees. And then we're looking for the patient to tolerate being up that high. We're looking for the cannulation site to tolerate being up that high. And then we're looking for the patient's limb vascular exam to be stable when they're sitting up that high. And if all those things are a go and the circuit tolerates it, right? So we're up and the circuit doesn't have any issues flowing. We do all that before we get up so that it's not, we sit up at the edge of the bed and we're finding this out first thing sitting up at the edge of the bed. It's kind of the screen for mobilization, if you will. So doing that beforehand so that you have, again, a working idea of, oh, well, the circuit doesn't tolerate flexion past 50 degrees. So we can't sit up on the edge of the bed, or we're going to sit up, but we're just going to lean back so that the patient's not so flexed up and we can maintain flow. Or we're just going to put them on and slide them over to a tilt table and tilt them up so that they don't have to do any trunk flexion, but being very thoughtful about that prior to mobilization. I talked about securing cannulas for planned, for stabilization with all planned activity. Again, that's that concept of going through the totality of the planned mobilization and making sure anchors are in places that are going to be secure, but are going to offer slack and not too much tension. And then understanding the patient's current level of support. And this is going to be that communication piece. So during that chart review, me understanding where the patient is in their current level of support on ECMO, where are we in their ECMO run, what is their current level of support, and then going, and when I go in the room and I'm starting to have these conversations about mobilization with the team, being very clear, okay, we don't have any room left, we can't on flow, or we don't have any room left on sweep, or we don't have any room left on FDO2, like we don't have room on this stuff to support the patient. So is mobilization really the thing we should do today? Because there's no room. If something were to happen, there's no room to support the patient, to get them up and mobilize them, or get them up and mobilize them, and then if they show signs of decompensation, to get ourselves out of a pickle. This flow diagram was actually put out by a group out at the University of Utah, and it speaks to critical management of patients in the critical care setting, but also ECMO patients. And it gives I think a very good kind of schematic of how to progress, when to progress, and is a good resource. But what I like about the tool in and of itself is it says that it's a guide meant to be a framework for decision making and mobility, and should not take the place of good clinical judgment, and that things need to be individualized. And so being able, again, to communicate, evaluate, assess, and reassess is important when we're managing these patients who are supported on ECMO. This comes from the neo-peds world of ECMO support. And I really like it. It comes from a consensus article of experts. So PTs and OTs working over actually in Europe, who are managing patients who are supported on ECMO. And what I like about that first kind of flow diagram is that there's consideration for that preparation phase. And in their preparation phase, I don't know if they knew it or not, but they're kind of walking through that A through F bundle, making sure they're ticking all the boxes. And then in actually the mobilization phase and the kind of the post-mobilization phase, there's built-in places where we're continually evaluating, assessing, reassessing things, which requires effective communication. And effective communication is me speaking the same language as the nurses, as the ECMO specialists, as the respiratory therapists. So when they say things to me, I can incorporate that into kind of the mobilization plan. A little off topic, but when the ECMO specialist or perfusionist says, "Hey, Erica, we sit up and my venous drainage line pressures are going up," I know what that means. Or when they say, at our facility, the perfusionists know that I want the patient's venous sat with every change in activity or with strenuous, whenever we do anything. So I'll just hear random numbers being yelled at me. We stand up and I hear 75, 62. And so I know what information they're giving me, so I can gauge, oh, well, this is too hard for the patient, or this isn't hard enough, or yeah, we can progress. But that is effective communication. So back to the schematic, sorry, got off on a little tangent. But what I also like about this is then the experts then took the patient's clinical picture and they kind of divided it up into the different organ systems and different considerations. And then they risk stratified them as high, medium, or low risk. And then based on where the kiddo kind of falls on this high, medium, low risk stratification, they have come up again with activities that are age appropriate, developmentally appropriate, but also clinically appropriate given the patient's clinical presentation as high, medium, or low. So I really love this, and unfortunately, there's nothing like this for the big kids yet. This slide, and I'm kind of sorry we lost it, but it's a pyramid that shows kind of the progression of mobilization, and so it kind of reinforces the thought that when we're mobilizing, we start with like, can you be a human? Can the circuit support you with bed level activity? Just kind of rolling side to side, bridging. Are you able to hold flow when they're changing your sheets, when you're getting on and off of a bedpan? What does that look like? And then can you sit up on the edge of the bed? And can you participate in sitting balance activities? Oh, can you stand up? Can you weight shift? And then at the very, 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 very top of that is, can you stand and walk and ambulate and hold decent hemodynamics, and then the circuit adequately support you? And so there's really this progression of activity. We can't just jump into things. Not everybody's going to walk. Not everybody's going to sit up on the edge of the bed. I think the take home here is that there's something we can offer everybody at their level of mobilization. It doesn't necessarily have to be standing and walking. With respect to activities at different levels of mobilization, again, bed level mobility, there are a bunch of companies out there now that offer kind of the option for verticalization, and kind of, can we start progressing patients to upright weight bearing in a safe way with the utilization of these verticalization beds? Can we, when you start thinking about kind of positioning, can we just put these on patients on these beds to kind of help manage their mechanics of breathing or their VQ match, or to kind of help their oxygenation, that kind of is that an added bonus for utilization of these beds? There's the traditional upper extremity and lower extremity exercises with TheraBand or shuttle presses. Cognitive activities, so keeping their patients engaged so that they're aware, alert, and participatory in their care. I think sometimes what's lost in this is also bed level ADLs and self-care. So can the patient, wash their face, brush their teeth? Can we sit the head of the bed up so that they can participate in their oral care that day? Can they do lower body dressing in the bed? Can they do upper body dressing in the bed? We can start some of these things very early. Again, not all patients are going to walk, but there's something we can offer these patients prior to getting them to the ambulatory stage. Again, kind of a reinforcement of some bed level mobility activities, using eye gaze systems for communication. If we're not that high tech, just, can the patient text on the phone? Can the patient, if their handwriting isn't great, can they, text, use their phones to text, or use our phones to text so they can communicate? Utilization of the ICU diaries, and even assisting with splinting and positioning. Some really good things can happen as a result of kind of prevention. We don't have to let things get kind of down the road, and then we're working uphill against some of these functional impairments that happen as a result of immobilization. So, can we go by and do a little bit of education about, okay, so your patient doesn't need to lay in bed with their arms down dependent. They have a lot of edema on board, and all we're doing is kind of pulling on their glenohumeral, their shoulder joint. It'd be better to protect their shoulders if we position them kind of like up like this, and their elbows supported. Or can we put splints and things on them, and before we get to a point where they're up and moving around, so that we prevent some of these contractures, or as we talked about kind of in the evidence or research portion of things, to kind of prevent some of those skin breakdown issues that happen with patients who are supported on ECMO. Again, progression to the edge of the bed and sitting balance activities. I really love that little that sitting and walking thing, the little sitting treadmill. I want to get one, but again, to kind of illustrate, there are things that we can do when we're thinking about mobilization of these patients outside of ambulation. What I will say about the inclusion of diligent lifts, in my practice, we do use diligent lifts to assist with mobilization of these patients. I would say the key is making sure you can visualize the cannulation site at all times, that we're not draping any of the tubing over movable pieces of the diligent lift. So if there's an arm of it that's going to go up to help the patient stand, that we're not draped over that just in case it tugs or pulls. And that things are kind of away from those movable parts. But and that's when you're using these slings to kind of help secure patients into these lifts, that we're padding things up so that things are not rubbing, pulling, and have the ability to kind of either make the cannulation site look worse, make it bleed, or pull a potential cannula out. with respect to functional progression, we are going to look at the patient's tolerance. So understanding what the patient's signs and symptoms of intolerance are going to be given their clinical scenario. And it's so tough given the variability of clinical presentation with patients supported on ECMO. And that's why there's the necessity to understand pathophysiology and how the circuit is supporting the patient. Because it's really hard to give a hard and fast of, I think sometimes people want, if the heart rate goes up by 15, but like, it's very hard to give that as a general rule of thumb. It's easier to educate and let people use their clinical decision making skills with respect to progression. And then the ability to adjust the circuit for appropriate support. So, and again, I said at the top of the talk, that's when it gets a little bit that's when the critical thinking and clinical reasoning takes place, when you can use that circuit to help support the patient so that you can maximize their return to function. So understanding, okay, well, the patient is, their lungs are still not recovered. Their lungs are not participating in gas exchange as much. So the circuit is what I have for gas exchange. And so I want to do more intense activity. I think the patient can tolerate it. We're going to be a little bit more aggressive about our sweep gas flow with activity. Or sometimes at our facility, they use us as a kind of I like to say a stress test for trial off. So the circuit is turned pretty much off. We're at 21%. The onus is on the patient, and it's like, all right, do the thing, get up and be a human being, and let's see how you tolerate it, so that we have some idea of what you may potentially look like off of this circuit. So again, having an awareness of what's going on with the patient, where are they in their run, what clinical intolerance looks like specific to that patient, and sometimes to that circuit as well. Being able to troubleshoot issues and circuit alarms. I would say that sometimes the first alarm, everybody's like, okay, it's alarming, we're done, we're back to bed. And sometimes that's legit, sometimes that's legit, but really, is there a way, if we're speaking the same language and the ECMO specialist says, so, hey, Erica, I'm having issues holding flow, my venous drainage line pressure is getting more negative, we've dropped our pressure, like we're having that conversation real time, and while we're managing the patient, that's a better utilization of our time and resources, and we're getting bigger bang for the buck, as opposed to as soon as that happens, we're laying back down. And we're as opposed to troubleshooting in the moment. And then establishing a pre and post mobility checklist is huge, so that every single time you're doing the same thing on the patient. And sometimes people are like, well, nothing bad has ever happened, and my response is, and this is why nothing bad has ever happened, because we are doing these things the same every single time. These things that we've said are the safe things to do to make sure the circuit's good, the patient's good, and everybody's on the same page. We do these things every single time before we mobilize, and we check it off again after we mobilize. So having a pre and post mobility checklist is huge. I spoke to the effective communication. So establishing a role and responsibility for each discipline. Again, I want to know what's going on during mobilization. And so I want to know what the ECMO specialist or perfusionist is doing, what respiratory therapy is doing, what the nurse is doing, again, what the patient is doing. So if we have a working understanding of everybody's role and responsibility, it makes that way easier. We also want to be, as I've said a couple times in this lecture, speaking each other's language. It is a different conversation. And when, again, the ECMO specialist says, I'm having an alarm, as opposed to, hey, Erica, my SpO2 is coming down, or my SpO2 is going up and my peripheral sat is going down. And I'm like, oh crap, we're recirculating. What does that mean? Do we need to sit down? Like, we're having those conversations real time. Establishing a stop word, and that stop word is stop. Sometimes, patients who are on for a long period of time, we have, give them some control, let them choose the stop word. We had a patient who would choose the stop word every day, and the stop word one day was banana. And I thought about it after, and I was like, that's like 3 syllables. It needs to be very clear and concise. Everybody needs to know the stop word. And everybody needs to understand when the stop word is said, you stop and you have the floor, and you need to, again, be as clear and concise as possible about what you see and what your concerns are. And then establishing a pre and post mobility assessment, as well as conversation. So who do I talk to the nurse about this? I talk to the respiratory therapist about this. I talk to the ECMO specialist about this. I talk to the patient about this. I talk to the cannulating physician about, like, being very intentional about your conversations amongst the team, so that everybody has a good understanding of the plan before, during, and after mobilization, and then a conversation after as well. So I like to say everybody looks stable laying in the bed is when you sit people up and kind of do things to them that things can get sometimes sideways. And that's not necessarily a bad thing. That gives, I think, a lot of good information to the team. You may think the patient is, looks really good from a hemodynamic standpoint or looks really good from a volume standpoint, but when you get them up and move them around, you learn the opposite. And so that helps the team then manage the patient more effectively. But to do that, they need the information. And as speaking specifically as PT and OT, we need to be able to give that information. Yes, giving the patient was min assist and stood up and took 25 steps, like that stuff is important. Functional stuff is important. But what the docs and surgeons and the provider team really want to know is, did they hold a good SAT? Did they have a good blood pressure? What did the cannulas look like? What did the circuit look like? And being able to communicate that is super helpful for the patient along their run on ECMO. And so really quickly, I know we're a little bit over for time, but I wanted to jump into this case. We have Mrs. B. She's a 65-year-old, 89 kg female who has a past medical history significant for CAD, has had an NSTEMI, has had a couple stents put in, has had bypass, has some hyperlipidemia, OA, hypertension, smoked a couple of years ago, but has quit, has some AFib, diabetes, and has some heart failure and a life vest. She was admitted to the hospital in cardiogenic shock that was refractory to all medical management, ultimately requiring intubation and cannulation for VA ECMO support. She is cannulated in a bifemoral strategy with a left drain cannula and a right femoral return cannula, and also has a distal limb perfusion cannula intact. Following cannulation, the patient was able to wean from most vasoactive drips, has a little bit of epi in the background to help with contractility. That's been overall stable for the last 24 hours. What's cut off a little bit in this slide is that her echo showed that her LVEF is about 8%. Her RV is down as well. And what I will say about also, and I didn't say this, and I apologize, in the cardiac stability, looking at some of this stuff and understanding where the underlying organ system is, the heart and the lung, also gives you an idea of how big of an emergency it's going to be if we lose flows or ECMO support. Is this like patient has no contractility underneath, has minimal, his contractility is pretty good? Like, it will dictate the response to activity or the response to lack of flow or decreased flow during ECMO if something were to happen. Same thing with the lungs. On rounding, the plan is we're going to diurese the patient. There's no ECMO circuit changes that are going to be made. They're going to drop a DOP off to feed. They want mobilization, so they've consulted PT and OT, and the patient has been made, the referral has been made for advanced surgical options evaluation, and that process continues. On her chart review, what we see is that her contractility is relatively stable, relatively, I would say, intact and stable. She's on, again, a little bit of epi and no current and on current ECMO flows. She's been fine. Her vital signs look overall, again, pretty stable. We've talked about her echo. Her EF looks good. Her EF is not good, but her EF is about 8%. RV is down as well. But again, that tells us a little bit about her heart if the ECMO circuit were to cut out. She's clearing her lactic. From a pulmonary standpoint, her lungs are a little wet, hence the diuresis today. The plan for diuresis, her ABG, not circuit ABG, looks overall pretty good. From a respiratory standpoint, those indices and vital signs of to evaluate her pulmonary system look pretty good, look pretty stable. Her H&H is pretty stable. She has good carrying capacity overall. And as a trend, they're stable. There's not been many undulations in her H&H, been pretty stable. She's awake, she's alert, she's appropriate. She is on a little bit of low dose dex to maintain that awake, alert, appropriate, and cooperative state. From an ECMO standpoint, her RPMs are 3,200. She's flowing at 4.1 liters per minute. Her FDO2 is 40% at 5 liters per minute. Her SpO2 is 68% stable. Her distal limb perfusion cannula is stable, and her right lower extremity vascular exam is grossly intact. What we've communicated, what's been communicated by the nurse prior to mobilization is that the patient did in fact get diuresed earlier today with overall good response. Her flows have been stable, rolling in bed and doing daily cares. Her cannulation site is pretty stable. And currently her anxiety has been well controlled on low dose dex. ECMO specialist and perfusionists report stability out of the circuit, and distal limb perfusion flows have been stable, and respiratory therapy says stable, no changes from their standpoint. During mobilization, we complete that pre-mobility checklist. The patient's alert, she's appropriate, hemodynamically stable, cannulation sites again look stable. People tell you, and then you go put eyes on it and you see for yourself. All sutures and anchors are in place and positioned appropriately, and we've established a stop word. But with the transition to the edge of the bed, the ECMO specialist reports some elevated drainage line pressures and difficulty holding consistent flow. So they're going to dial down their flow a little bit to see if they can kind of stop the chug and chatter that's going on. And with the interruptions in flow, there's been variability in the patient's hemodynamic and the patient hemodynamic presentation. The patient is symptomatic with drops in flows. So the discussion here is what clinical change had taken place with the transition to the edge of the bed. So with the transition to the edge of the bed, the patient had been diuresed. So there's a couple things that could be happening, right? So the patient sat up, volume dropped to their legs, and we got a little bit of chug and chatter, or the patient sat up and physically kinked off the drain line cannula, compromised it a little bit, and doing such caused some chug chatter. And so how, as the multidisciplinary team, could we safely troubleshoot or resolve this issue? So as the team, we're going to look at the first concern is always the patient. So the patient is symptomatic, so the decision needs to be made: do we lay back down and start from scratch, or the ECMO specialist or perfusionist saying, hey, Erica, I'm going to dial down my flows a little bit and see if I can stop some of this chug and chatter. But the question is, when they dial down the flow to stop some of the chug and chatter, does the patient tolerate the decrease in support, right? So I think we were flowing at 4.1. If we dial down to 3.25 and we have less chug and chatter, does the patient tolerate it if it's actually a volume issue? Or is it, hey, me saying to the ECMO specialist, hey, hold on one second, I'm going to lean the patient back a little bit and say, and let me know what that does to your flows. Or I'm going to kind of move them this way or that way. Does that help your flows? Right? So it's that interdisciplinary team communication that's going to help troubleshoot or resolve that issue, so that either we're back down, and if none of that works in the 2 minutes, minute and a half it takes to make those decisions that kind of do those things, none of that helps. Patient is symptomatic, we can lay back down. This patient's super symptomatic, has no blood pressure. Again, first things first, get the patient safe, and then we can figure the rest of that stuff out. What information was gained about the patient's clinical status that would be helpful to report back to the managing team? So we could talk about the patient's hemodynamic response to activity and what drove that, again, hemodynamic response to activity. Did we diurese and lose some intravascular volume, and while we were fine kind of laying flat in bed, but when we challenged them with gravity, things got a little sideways. Kind of helping the team again with the overall clinical management of the patient. And then we see how kind of dependent, I think we would know how dependent the patient is on the circuit when we lose flow, given their echo and their EF and the right side being down and left side being down. But it's good information. And then how would the patient's performance during the initial mobilization session impact subsequent sessions? So then as a team having the discussion of like, do we mobilize and then diurese? If we think it's a mechanical obstruction, do we get them on a tilt table and avoid any degree of trunk flexion and just let them stand up so that they can walk off the edge of the bed or progressively weight bear from that position? But being very intentional about using that information so that you can then plan for subsequent treatment sessions. Last slide. Thank you so much. I know I went over a little bit. I start talking about this and I get long-winded, but thank you so much for taking the time to hang out with me, listen to me, and listen to me talk about something, again, a topic that's very near and dear to my heart. If you at all, or your facility is all interested in learning more about ECMO mobilization, I do partner with a company, ECMO Advantage, that does fabulous just general ECMO education, but we have a course specific to adult ECMO mobilizations, high fidelity sim. Again, get the information, feel it, touch it, practice it, so that when you go back to your facility, you're more comfortable utilizing it or instituting it into your program's mobilization plan. And then if any of you want any of these articles that are referenced, the PERMI ICU competency, any of that, please do not hesitate to reach out and I can provide you with those. And again, thank you so much to Nicole and ECMO Resource for her having me. It was fantastic. It was a fantastic time.
Well, thank you so much for joining us, Erica. Fantastic presentation, so much practical information that's been offered. Just another quick question from your perspective, because you've probably worked with so many different programs and nurses and physical therapists and managers get involved in administration and all of that, which is so much fun.
Yes.
What, from your experience, what are some of the biggest barriers or most common barriers that you've seen between ECMO departments and ECMO patients being mobilized in the hospital?
The first thing that I think of is kind of the tendency sometimes for us to practice in silos. And so kind of breaking down that initial, it's not a hesitancy, but facilities normally say when you bring everybody together, they would say, I didn't think you wanted to know that. I didn't think that was important to you, or I didn't know that that was what you did or what you thought or what you needed to make a good decision. So sometimes it's breaking down those silos and getting everybody in the same room so that to hear the same thing. Establishing effective communication. As the research says, like a team that is safe is a team that is efficient, and for you to be safe and efficient, it's good communication. And so establishing effective communication about what the ECMO specialist or perfusionist or ECMO program wants to hear, what the rehab program wants to hear relative to mobilization, so that again, everybody is getting the information they need to make the decisions they need to make relative to providing safe care for these patients. So it's a siloed care, effective communication, and then resources, having the resources to do what needs to be done to safely manage these patients, so that you can get there, but doing it safely requires, I think, sometimes taking that initial step back so that you can do a good overview and plan. What do we have? What are our goals? What do we need? Where do we need to be? What are our resources? And how can we do this safely, as opposed to kind of just jumping in both feet forward to do all of the things. I would say the biggest thing. And I think once you break down those barriers, establish effective communication, and give people the tools they need to do their job, like amazingly wonderful things can happen in the care of not just patients supported on ECMO, but all patients. It's amazing what can be done.
Thank you. Thank you for sharing that. And so in closing, if you could just share an encouraging word, something that's inspiring that you would want to leave with ECMO clinicians and ECMO specialists all over the world, what would that be?
My encouragement would be keep doing what you're doing. You're doing amazing work to care for some of the sickest patients. And if you were not there, so in some cases, these patients would not be there. And so even though it's hard, keep doing what you're doing. It makes a difference.
Thank you, everybody, for tuning in. It's been an honor to host another ECMO specialist workshop. Thank you for joining and taking time out of your day. Feel free to share this with other clinicians, rewatch whenever you need to. There's a lot of helpful resources and reading material that's been referenced. Get in contact with Erica, go to one of her physical mobility sessions, email her, call her. She's such a great resource, and I can't wait to connect with you all again.